Unstable Vitals is the podcast that takes the pulse of American healthcare, and the prognosis is critical. Dr. Adam Brown and Dr. Lara Zibners, physicians turned entrepreneurs and business leaders, expose why the system is unraveling before our eyes.
Well, hello, it's time for another exciting episode of Unstable Vitals, and I am so excited to be here today with my good friend Rui Ariyapala. I've just screwed up your name. We're going to start that over. Ariyapala, did I say that right?
That was 10 out of 10. You don't have to, you just have to
Was
give
it
it to it. I know
really?
it's 5 syllables, you just got to go for it. You know, just trust your gut.
Okay, really? Okay. All right, we're going to start over.
I thought you were here with your good friend Lara.
No,
We usually
We're starting
start like
again?
that.
Hang on.
no. See, that was the
Oh no, I
joke
think we
I
should
was
keep
coming
all
in.
of this.
I think we should just keep all of it.
I think we keep all of it. Hey Adam, what's up?
Hey, well, first, I want to talk with Rui. He's like so excited. I got to see him a couple
Yeah.
days ago. I'll get to you.
No,
in a
but
second.
that's not how this works.
Okay, that's right. Hey, I am so
He gets a
excited to be
proper
here today.
intro. Where are you sitting today?
Oh, I'm sitting in my chair in my office in my London office. So very excited. We have gotten our flat pretty much done, and we have a terrace, and I've gotten my 2 olive trees in this week. I've got my uplights. I mean, I know these are not like big priorities, but I've also got my first mouse. And when I talked with my friends, they said, "Welcome to London." That's a part of the Welcome to
yeah.
London committee.
Oh yeah, I used to have like a whole little family of them that would be in my kitchen every evening. I also just moved house, and it turns out because there's a gym around the corner, we don't need our like half of a living room as the home gym. So I'm turning one part of it into the book nook, the reading nook for the kids, because I have hopes that one day my children will actually pick up books and read them. And so I was showing my daughter the furniture I bought, but she saw this lamp and she's like, "We need that." So I bought it. That's the first thing to have arrived. It is a lamp with a 14-inch gold embossed parrot perched on the lampstand. And we named him Gary the Word Bird.
So, and this was all back to the I'm trying to follow the trail. This starts back with reading, correct? Like this is a lamp
That's right.
for the reading room.
Right. But my daughter, and I'm like, if my kids will pick up a book because Gary the Word Bird is sitting there, I feel like Gary the
That's,
Word Bird will be worth it.
that's
Anyway,
really
we were
nice.
just in London together, weren't we?
We were. I mean, it was a really fun event. So I've got 2 funny things to tell about this event. So, and then we'll get to you, Rui. This is really about Laura
I'm
and me,
loving
so we'll
it.
get
As
to you in a
a
second.
British
So,
person,
Yeah. Just
I want to hear
sit
your
back,
take
sir.
on London. I'm quite...
okay, well, I'm having a blast. I absolutely love it. But Laura invites me to this thing called ZSL London, and I'm just like, oh, this is very cool. What is ZSL? So I, for days, was looking up ZETACELLE. I'm like, what in the hell is ZSL? I'm like, she goes, well, it's at the London Zoo. And I'm like, okay, cool, ZSL, that sounds cool. So I get to the event, I'm all dressed up, in my little tie and all this.
First, you tried to flake. You tried to call me and tell me you were too busy. And I was like, no, you don't understand. I got you into this event. But Adam has not hung out with me in London much. And, I moved there 20 years ago this summer. So I kind of had a life that
So
he has not tapped into.
Exactly. So I thought this was like an event that was like a ton of people, and no, she sends like, no, Adam, you're coming. Here's like your name card sitting here, and here's a special guest over here, and here's a countess of something another over there. So number one, so I'm like, okay, I'll be there. I'll be there. I'll go. So I get there, and they're talking about welcome to ZSL, da 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 da, and I am just like, okay. So I'm just thinking, all right, I'm just rolling with it, ZSL. Then the really cool thing is I got to meet Ginger Spice at this, which was like totally awesome. She's gorgeous, by the way, super
It's
smart.
gorgeous and so teeny.
Yeah.
Like,
I mean, she was, I think, I can't remember, she was Ginger Spice, but my friend Chio told me that they call her Smarty Spice because she's quite intelligent, in which I saw that on display when we were talking about conservation. But this is where ZSL comes out to be funny to me. So I come home and I decide I'm going to write an op-ed about this because one of the things that I learned from this London event was that releasing endangered animals into the wild is almost like releasing new AI and technology products into the wild. And the
Oh.
challenges are not actually the release and the press release. The challenge actually is the fact that is the getting them adapted to their new unendangered but still dangerous environment. So I'm writing, looking up Zeta cell, and then all of a sudden it hit me. The letter Z is
Is
Z.
Zed.
The letter
It is
S is
Zed.
S and L. ZSL is
Yes.
Zeta
Oh,
cell.
I had a hearty laugh, and I did send that phonetic spelling to the ladies in the development office at ZSL, where I have been involved for years, and I've been a patron. And you go in like I like to be involved in philanthropic efforts that not only better the world, but my children can actually like go and see. And so we've been involved for years, and it turns out Jerry got involved kind of the way, I mean, Ginger, the way I did, which is I rocked up with kids that I needed to entertain. And I was like, there's a whole zoo in the middle of the park. And then you find out that if you go in, you become a member. Well, that just got, paid for 2 visits. And then you find out if you up your membership, well, the grandparents can go in for free with the kids. And then it's just a slippery slope from there. But yes, and Ginger sat next to my hot husband. And the first thing I said was, hands off my hot husband.
And all I wanted to do was meet her to go out for tea or something. But anyway, we got cool pictures. She
We did.
liked us. We talked about our podcast. We talked about our businesses. It was, I mean, it was only a group of maybe 20 people. So it was kind of like a
Hmm.
cool event. So thank you, Laura.
You're
Um,
welcome.
I want to go
Guess
over to
guess
you
where
and talk
I
about Ohio.
yeah, guess where I am. Oh,
Okay.
I'm in
Ohio.
Cleveland. And tonight I'm heading to Columbus. And I'm going to Columbus because I'm a Buckeye. I trained OSU Med School Residency Fellowship. And I'm launching pretty soon the world's first, I believe, world's first advanced competency for senior medical students called Entrepreneurship in Women's Health. My first victim, I mean student is in August. And so I have a master's in med ed, so I got a little street cred. I will say, Rui, we're going to get to you in a minute. Well, when I looked at you, I was like, I rarely meet somebody with as many letters after their name as I have. So
I
well
also
done,
have a
you.
master's in med.
Anyway,
We need to
so
talk
I'm going
about
down to
that. Yeah.
Columbus. Okay, all right, okay. I saw that. And little competition here. But I'm in Cleveland because there is a WHAM, which is the Women Alzheimer's Movement, which is Maria Shriver's organization, and Cleveland Clinic Global Women's Forum. I am friendly with these folks, and I was invited last night to a very exclusive welcome reception. And guess who I was hobnobbing with?
Who?
Miss Shriver, who is a tough nut to crack, but I think she's starting to like me a little bit because she didn't look pained to be standing next to
Yeah,
me.
your last picture with her looks like she's like,
She
who is
looked
this
right.
crazy
No. And I
person?
said to
And
her, I
where's my
said,
security
last
badge?
time I got a photo with you, thank you for, because that really did my social media wonders, but I know you were super annoyed that I grabbed you at the last minute. Maybe this time I can get one where you look interested to have met me. So I've been assured, but I didn't get the pictures last night because I didn't want to be like that person. So I've been assured that today her people are going to make sure that I get a photo where she looks be to have me in her sphere.
So it's manufactured, is what you're saying.
100%.
Got it. Got it. Well, hey,
100%.
can we talk to Rui for a minute?
Yeah, now we can bring him in. All
Hey,
right,
buddy,
that's
how's
fine.
it
For
going?
me,
It's good to
you can
see
keep
you.
talking away. This is great. This is my entertainment. This is wonderful.
Well, she's my entertainment a lot of times, you know. So so it's always fun to talk with Laura and hear about her shenanigans and also funness. So and then when we get to do shenaniganing together, that's a word.
It
It's
is. It's like a koalalologist. We
a
make up lots of
koalalogist.
words.
We talked about
Yeah.
that. You're from kind of sort of near the down of the land down under,
Quite
right,
almost.
Rui?
I'm from New Zealand initially. Yeah, originally I grew up in New Zealand. Yeah,
It's out there.
That is so much better because they don't have poisonous
yeah.
creatures
The only thing we need to
everywhere.
fear is we have 3 sheep per human being, so we have to worry about that ratio. That's the biggest worry that we have to deal with.
Where the nights are long and the sheep are lonely. Is it one of those kind of
Stop it,
places?
Laura. I was going to say, Laura, there are no sheep innuendos, you know?
Bah!
Yeah, sheep, Lord of the Rings, and
Oh,
rugby, I think, fuel the New Zealand economy. So that's kind of where I grew up. But yeah, we can talk a bit more about that. Yeah, I'm looking forward to this. Thank you so much.
You don't
Listen,
sound
I have a
Kiwi.
story about that, and that it relates back to the UK. So I grew up in New Zealand until I was 13, 14. I went to high school in London, just north of London, in a county called Hertfordshire. So I'm actually half British, half Kiwi.
Yes.
Yeah, there we go.
Okay, yeah, so I met you at UNC and was really impressed with not only the work that you were doing as a resident, but also kind of your direction of where you wanted to go. So, Rui, I'll just throw it over to you. Introduce yourself a bit. You know, we've talked about the Kiwi side of things and the London side of things, but give us more of kind of who you are, what you're
Well,
about, what
first
your
of
background
all,
is.
Lara, Adam, it's such a privilege to be joining you today. I didn't realize how fun these podcasts were going to be. I wanted to make a special thanks to Adam. In our interactions, you were a guest at one of my podcasts at UNC Health, which was Tar Heel Wellness, actually focusing on physician burnout and how we can address that. So just wanted to say it's great to collaborate again on this. But yeah, so bit of my funny accent story. So yeah, I like I said, I grew up in New Zealand, and what's very interesting, like looking back now, I was only a child going through, living through New Zealand, but there was so much actual public health that was already ingrained in the lifestyle and the culture of New Zealand. I remember there's a sport in New Zealand called netball, right? It's kind of like basketball, but women tend to play it. New Zealand's the world champions. And I remember in the final.
Did you just say it's like basketball, except women are allowed
No,
to
no,
play it?
women predominantly play it. I'm sorry. That's what I meant. It's for women.
Do women play basketball in the United States? I'm just
Yeah,
checking.
yeah, actually
I'm
they
joking. I'm
do
joking. Yeah, yeah.
because it's yeah, it's a sport that women are also allowed to come outside
Okay.
and play.
So my words
Oh,
clearly are going
okay.
to get minced in this one, clearly. But what I'm saying is netball is a sport that's predominantly played by women, and we are the world champions. And I remember as a 7-year-old in the grand final, it was against Australia. It said on the actual court, 75% of New Zealanders are smoke-free, which I thought was very interesting. And I didn't realize just how ingrained physical activity, lifestyle, medicine, and we'll talk a little bit more about that, was ingrained in that culture. We're always outdoors. We're always caring about nutrition and things like that. So that was quite interesting for me as a kid. I mean, looking back now, that was like clearly like a public health policy campaign. So I grew up in New Zealand with that kind of sort of upbringing. And then here comes the accent. So I was then, I transferred high schools into London, and I got into medical school. I went to Edinburgh, the University of Edinburgh, which was a really fantastic medical school. Really learned a lot from a population health point of view and social determinants of health, actually, and loved that experience. So you can go straight from high school to med school in the UK, right? But it's like a 5 or 6 year program, depending on if you do a couple of degrees. And so what was interesting, well, halfway through my med school year, I was really interested in technology and education. So I took a year out of Edinburgh and I went to Harvard University, where I focused on my first master's in medical education and technology. And what was interesting was,
I'm sorry, which
oh, that little,
university?
He just dropped that. I went to Boston. That's what most people do when they're trying to be subtle. I went to
Mm-hmm.
am I going to have a
Boston
hard
for
time
a
about this
year.
as well now?
Mm-hmm.
Okay. So,
No, go ahead. Go ahead. I mean, us
Go ahead.
little people, but go
I'm
ahead.
in a Harvard life science exec program right now that's like from one of the satellite
there you go. You
campuses
taught me. There
online.
you
Mm-hmm.
go. Why I was there was because it was really an interesting time. It was 2015, 2016, and this was when telehealth, telemedicine wasn't really a thing, right? So we weren't even billing for 20-minute video face-to-face calls at this time. It was still a very nascent stage. So I was doing a lot on medical education, and I did half my credits in the business school over there, where they had the Harvard Innovation Lab. And I was looking at telehealth startups and understanding that whole workflow process of launching a healthcare technology venture. And I realized that at that point, that there was a very important inflection of change, I think, coming in healthcare, specifically with innovation. So like I said, there weren't even CPT codes for billing for telemedicine. I realized this might be something I want to pursue. I was still an M3, so I still had 1 more year of med school left back in Edinburgh. And I realized I wanted to get involved in more the business of healthcare, the innovation of healthcare, and understanding how systems worked. So I did that 1 year stint, loved it, came back, wouldn't recommend the winters. I don't think my body's built for the Boston winters. That was seriously an experience for me. I came back to Edinburgh, finished my final year of med school, and then after med school, you have to do 2 years of training in the NHS, which is the National Health Service, universal healthcare. So you do all these different rotations. And for me, I was grateful. You know, you do your general medicine rotation, general surgery, ICU, you know, diabetes, endocrinology, anesthesia. I was able to, you know, sometimes you just get these rotations allocated to you. I had a public health rotation. So I was a public health physician as a junior doctor, or an intern, so to speak. And I was working with the local health departments in England. This is in the middle of England. This is near Birmingham at the time. And I just realized that you could do so much on a population health level that was, for me, very fulfilling. But I wanted to tie back to what I was interested in, when the business of healthcare and innovation and how we look at the health systems altogether. So that put me at a little bit of a career inflection point of like, okay, now what do I want to do? Obviously, life happened while I was in the States. I met my then girlfriend, now wife, now mother of 2 beautiful children. And, you know, she went over to live with me in the UK. She got a second master's after that just to be with me. So I probably thought, maybe I should propose to her. Maybe she does like me a little bit. So I did. We proposed in a escape room, by the way, which I rigged all of the clues to be like our anniversary dates and things. It was like a Leonardo da Vinci Code theme thing. And then the ring was in the Holy Grail at the end, which was quite fun. But so we got engaged.
Ooh.
Yeah.
Wow.
Took me
That's
6
some
months to prepare
effort.
that, and it was a really fun event. Her 2 best friends were in on it. They all came in from Puerto Rico. My wife's Puerto Rican. They all came in, so it was a lot of fun. And she had a great time in London. She worked in London. But then it was like we were at this point in our life, like, what do we do? Like, where do we want to be? And so I was a physician since 2017 in the UK. And then I was like, you know, she's got a big family in the East Coast of America. She's got a sister in Boston. And then, you know, there's a lot of innovation already happening that I was really interested in the United States. So then I decided to do something that I would not recommend, is to sit the USMLEs 10 years after starting med school, which is what I did. So yeah, that was
Yeah.
fun. That was a very humbling moment,
Yeah.
I think. But it was great. I, you know, passed everything first time round. I got matched into my intern year in the US in New Jersey, in Hackensack Meridian Health. And it was there also I was appointed as chief resident. And again, I was in these environments where I was doing healthcare management, you know, doing a lot of cross collaboration with the strategic side of the hospitals and the program directors and, you know, the C-suite of how we can implement and make, you know, the program smooth. Caveat, it was 2021, so it was during the Omicron wave of COVID. So I was, you know, managing 18 physicians in the ICU and trying to figure this out all while I was still working. So that, I think professionally, that I learned a lot about myself and how to navigate conflict and stress and, you know, scheduling issues and things like that. So I really enjoyed that. But my still North Star was still public health, prevention, and how to get into population medicine. And that was when I got into UNC, which was the general preventive medicine and public health program. And when we landed here in Chapel Hill, my wife and I just said, yeah, this is probably where we want to set up roots. And lo and behold, you know, we have a home now here and 2 beautiful kids. And that was when our paths, Adam, crossed, because I was doing so part of your training, for those that don't know, so, you know, there's different specialties like surgery, medicine, anesthesia, pathology, dermatology, ophthalmology, but preventive medicine, it's a very unique rotation where you have to do mandatory government health agency rotations. You have to do the VA, you have to do clinical work, of course, but you have to get an MPH done, right? So you either come into the program with an MPH already completed, or you do the MPH as part of your training. And so I enrolled into Gillings School of Global Public Health, #1 public health school in the US. Whoop, whoop, go Heels.
He's really subtle, isn't he? Drop,
I know, but it's
right?
warranted. I mean, it's warranted.
It
Really,
is warranted. And
Mhm.
if, yeah.
I mean, we dropped
there you
Ginger
go. So yeah,
Spice and
you
Maria
drop
Shriver.
bombs everywhere. So,
So, like, you know,
Yeah, no, I mean, good
but
for you.
But what I'm saying is
We're,
why that was so wonderful for like the experience of going to these sort of graduate schools is you have the ability to cross-register and you have the ability to explore other other school, public health schools or other graduate schools. And so what I did was there was a conference back in November for the Center of Business of Health, and it was like a research symposium. And I realized like that kind of ties back to what I was really interested in with innovation, population health, and how health systems worked. And I met Zoe, and I met Josh and Suzanne from CBOH, and that's when I was introduced to Adam. And so then I understood like that you had this amazing curriculum in the business school in Clean and Flagler, where you are able to focus on the business of healthcare and healthcare concentration. And so I really was enamored by that. I took extra courses in the business schools, healthcare marketing, drug development, health insurance and regulations, because I realized that's where my career I wanted to understand more about. So that's my story, and that's how I met Adam, and that's how you unfortunately stuck with me in this
So,
podcast today.
no. It's
Lucky
great.
us.
Yeah, so I wanted to start off like with one question because one of the reasons why I really thought it'd be great to have you on is, we're talking about how the healthcare system in the United States is unstable, and we're talking about how there's multiple different challenges from the regulatory system to insurance to politics to patients having access, et cetera. But when you left your program, your residency training, et cetera, you went to work for a federally qualified health center in central North Carolina that actually has multiple different clinics, and you're their associate chief medical officer there. So I'd love to hear kind of a couple of things. One, what is an FQHC? What is their role? Because I certainly, as I learned more about it, there are a lot of myths that I had about them that were dispelled. And then secondly, tell us about the patient population that you serve and some of the challenges.
Yeah, so great question. And, I was extremely fortunate to be part of this senior leadership team that really is mission and vision driven, but with the lens of looking into what the next big thing will be in innovation to help our population. So yes, FQHC is a federally qualified health center. It's a community-based health center. It receives federal support, so we get a grant from the federal government to provide primary care related to people regardless of their ability to pay, right? So FQHCs are designed to serve communities that often have barriers to healthcare access, including uninsured, underinsured, Medicaid, Medicare, and commercial, but we have a large proportion of our patients, which is probably the, I guess the flip side to other healthcare organizations where uninsured and Medicaid are the vast majority of our patients. Now, with that, of course, with sliding fee scales and things like that, we have to find a way to be financially sustainable, right? So that's the beauty of working in an FQHC is we're very innovative of how we are able to, for instance, have primary care, pediatrics, women's health, prenatal care, behavioral health, dental, pharmacy services, member care coordination, chronic disease management, preventive care, medical nutrition therapy. We found a model where we're able to have everything in-house as much as we can. So therefore we are able to incur the costs or the fees that come out as we bill. And that's been a really fun project that FQHCs have had we've been around for 55 years, by the way, and we've been through multiple different economic crises over the decades, and it's just very interesting that the leadership puts the patients first, but also how we always try to keep ourselves sustainable. And we can talk a little bit more about that, but that's essentially what an FQHC is. So we see everybody, right? And so right now we can talk a bit about this as well. We are actually changing our EHR, so electronic health records, from a more dated system to Epic, and of course that will then allow us to integrate with the big networks that are around us, like UNC and Duke, through interoperability and HIE, so health information exchanges of the data. So we're currently quite literally going through this right now. We have our Epic Go Live launch August 4th, so we are right in the thick of it. But those are the things that I think allow us to really give the care and the true coordination of care to our patients. So we're proud.
Well, how come? How come this is the first
Uh-huh.
time I've ever heard of this?
That I don't.
Is because I lived under a rock, or is it because in my mind you had free
Mhm.
public health clinics, and then you had like
Okay.
resident clinics, right? Like that was our job when I did pediatrics, right? And we had our clinic and we saw the, you know, the Medicaid population. But you're telling me that basically you offer a full suite of services at an affordable rate to people
Yep.
in America?
Yep. I think, well, that's the thing. So that's what people don't understand. Well, the misnomer, I think, from FQHC is just how comprehensive our service is. And one of the things, obviously, we are 10 clinics right now. We're looking to expand, and we're looking to expand our providers. And, we have MDs, DOs, PAs, NPs, we have behavioral health, we have dental, we have clinical pharmacists now as well. So we are really trying to be as innovative as we can for the care coordination. Everything's around the patient first. We also have something called a PACE program, which is the program for all-inclusive care of the elderly, which is a capitated program. So if they're eligible, there's certain criteria. That's another all-inclusive care that we have 2 clinics that do that. So it's a very interesting place because of where we're at right now. I think there is a lot of potential, and we can talk a bit about value-based care. That's the kind of thing I try to help as a population health physician, how to lock in value-based care contracts, but then more than that, how to actually get the value-based care dollars that we earn for quality metrics, right? And how we can put that back as a whole new line of revenue for the organization. And that's where I actually was hired for this role. So I'm very excited to talk a bit more about that if you want. Yeah.
Yeah, I think one of the things that was very interesting when we had a conversation about this before was the comprehensive nature that Lara was just talking about. Is that what I had in my mind free clinics, which were oftentimes run by medical students, run by residents, attached into communities and not the best type of facilities. But when I started hearing from you about moving to Epic, having dental services within the walls of the clinic, I mean, listen, it's surprising to me that still in the United States, and even for that matter, even here in the UK as well, that dental clinics are kind of segmented away from the rest of healthcare as if our teeth are removable. Well, some people's are, but our teeth are removable and not a part of our health. And so I think that's thing one, but the thing two that I kind of think about is when you are serving an underserved population, that population typically has challenges that other people who are more well off don't have. And that's transportation issues, the ability to take off of work more, the ability to be much more mobile or have childcare. And going to separate locations for doctors' offices on multiple different days without the coordination becomes expensive. Just from a timing perspective, and adherence becomes even more challenging. And you're solving that problem by some way of saying, hey, we're going to build the services around the needs of the patient.
Yeah, absolutely. And that's not to say we try to get all the services in one day for that patient. They may have to come back subsequent visits, but you're absolutely right, Adam. I think that is the key, is how we can get them to come back because of their social determinants of health issues such as transportation. You mentioned transportation. Another thing that I'm also overseeing and helping with the chief dental officer, actually, she's wonderful, is mobile health units. We have 2 big buses with clinics inside, right? So we have 2 beds, 2 rooms that we go and take the buses to areas so we can determine by postcode where our hard to reach patients are, right? Where there's a high prevalence of high A1C or hypertension, and we're able to get them in for their visits. We also help with, unhoused shelters. We go there and we give clinics. We take the clinic to them. So that's something that we are really proud of, the work that we're doing, and we're looking to expand and always innovate. But coming back to the business side of things, I think it's very, very important to mention that this only works. We all collaborate together. We have to have a strong relationship with the operations team. They're in charge of schedules. They have to get ahead of the game in terms of how they come in, how the patients come in, how we have outreach enrollment coordinators that figure out if you're self-pay, you may be actually eligible for Medicaid. So we can flip a self-pay into a Medicaid, and then that becomes like a billable service, right? So there's so many different innovations that we're trying to do with insurers and payers to make sure that we can get the coverage that these patients deserve. So it's actually been such a fulfilling. I've been there for about over a year now, and every day I can just see the growth and see the vision. We have a 5-year strategic plan of what we're trying to do, and it's a very, very, very fulfilling thing, and I'd highly recommend everyone to read more about FQHCs. Yeah.
And what about the like? Do you have social
So yeah,
work?
we do. We have licensed clinical social workers. We have behavioral health. We have care coordinators. So sometimes, so I'll talk a little bit about how we do this because we have to partner with other organizations as well, right, to make the comprehensive care. So we have things called accountable care organizations, ACOs, and they help with our Medicare population through and Medicare shared savings program. So we get a benchmark for a patient that's Medicare. And if you are under that benchmark, that's what that savings you get. So our job is to make sure that we don't go over that benchmark, right? So we have to figure out ways to reduce ED utilization. I know, Adam, you're an ED doctor. The one thing you probably have seen is the frequent flyers that come through, right? Because they don't have that coordinated care. So you end up being the PCP probably for some of these patients all the time. Am I right, Adam, that you've seen that?
Well, yeah, and Laura, just to say, Laura is emergency
So
and peds, so she saw a lot more of this on the
Yeah, I
there
did
you go.
pediatric
peds
side.
Yeah,
EM, and I was in Columbus, Ohio, and sorry, but children's hospitals are rarely in the
yeah,
wealthiest part of
exactly.
town, right? You are the primary care and the worried parents and things that I didn't understand as a resident or in fellow that would make me mad. But now I look back at it and I think, yeah, those people came in because they couldn't get off work before then. And the doctor's
Exactly.
office was closed and they needed a note from a doctor so that they could go back to work the next day. I had a dad once, I was telling him his child had cancer, and he said, I'm really sorry, I need to go to work because now I really can't lose my
Yeah.
health insurance. And walked off, right? Like these things that you don't think about that are influencing what time
Yeah,
patients can
exactly.
access care.
Exactly.
Yeah.
So this is, and so I'm clearly preaching to the choir here in terms of the types of patients that you see through your doors, how we're trying to mitigate that. And that's our big focus. As you know, ED, going to a visit for an ED or going to an inpatient, becoming an inpatient admission really affects our costs here at PHS. So that's kind of the strategies that we're trying to do. So that's one way. We have something else called clinically integrated networks, CINs. So one of the ones a big one that we work in North Carolina is they come and bring in third-party care managers for high-risk patients. So they get through their doors, they manage their certain needs that they need to be addressed before they come to our chronic disease management visit, right? So I think having that collaboration, we have value-based care coordinators, we have APCM, which is an advanced primary care model of payment, where they have patient health navigators, pharmacists and nurses that come and help these specifically vulnerable patient populations to get the care that they deserve. So it's been it's been a whirlwind. I think a lot's happening always all at once, and we have to, keep abreast of what's happening with policies and things like that. But I think in general, our senior leadership has just got they've got their head screwed on in terms of where the vision is for growth and sustainability. And I think that's the magic of an FQHC.
So, so can we I forgot to mention that I'm deathly allergic to kiwi fruit, and the last time I had a bite of one, I was in an ambulance. So, but that doesn't apply to New Zealanders, so I thought we'd just get that out there. Um,
Thank you.
Number two, so I also practiced in the UK for a number of years, and I want to take this back to something I observed. I've found that patient expectations were quite different in the US versus the UK. In the UK, there seemed to be an acceptance that we have a national health service and we all contribute to it. And therefore, we understand that if we have something non emergent, we're going to be waitlisted, possibly for weeks to months. And there was an acceptance of that. I never felt that in the US. I felt like it was much more of a Burger King model. Like I want it my way when I show up. Can you speak to that, having also practiced in both sides, like the patient expectations and how they find the
Absolutely.
services?
I think you nailed it, Lara. Because everything is quote unquote free, we're still, it comes out of our national insurance, right? As a UK citizen, we pay towards our healthcare. But because we can go in at any time, excuse me, at any time and say get a total hip replacement, a total knee replacement, and that's our bill is in the US, I don't even think we can sort of comprehend that sort of payment structure, right? So with that, there is this underlying understanding that the NHS is really the backbone of the country's economic growth. If we have sick patients, we don't have the economy to run the businesses and all those kinds of things. So we understand that because we don't pay out of pocket, because it's a one-payer system, it's universal, that something has to give. And right now, of course, like GPs, which are PCPs in the UK, the wait time is increasing. Getting referrals is being quite challenging to get referrals or specialist care, unless if you pay out of pocket and go private. But you're absolutely right. Because of that, there is an understanding that maybe waiting for the next PCP visit in the UK, we're okay waiting a little bit later, whereas in the US, because of this model, it's that on demand. I think that mentality is something. It's an interesting dichotomy, because there are clearly pluses and minuses to both. Yeah.
Mm. You know, Rui, so now, you know, we all share now this connection to the UK. I'm now a resident of the UK and also the US, but going to the healthcare piece. So one of the pieces that for me to be a resident here is that I had to pay into the US, the NHS system. And so I paid, I think it was around $4,500 for health insurance. And when you say $4,500 at first, I say that to some people and they're like, okay. And I'm like, that was for 3 years of health insurance. And then they're like, oh. And then I'm like, how much are you paying? Well, so I also have health insurance in the United States that we pay out of pocket for. And we are paying $26,000 a year for 2 people who are very healthy to have health insurance. And so, you know, going back to your point about this dichotomy and expectations, I do believe that in some respects, when you're in the United States, there is this understanding that a lot of your employment income, a lot of the cost is going to healthcare. And therefore, and then even for people who are not let's say people who are not lower income, there's a lot of out-of-pocket expenses that are coming for healthcare. So because of this consumerization of healthcare, there's a higher level of expectation of the services that are received at times, versus here, to both of your points in the NHS, because everyone is paying into the system and everyone is contributing to the system. There are more kind of controls on utilization controls and when you can go in and capacity controls. However, the proof is in the pudding. People in the UK live longer. There's more social kind of construct around lifestyle medicine, preventive medicine type of practices. There is prior authorizations of some respects here as well, just that there are back in the US. So the systems are different, but and there are pluses and minuses to your point. But I think the out-of-pocket costs is what oftentimes Americans, they don't recognize or see, especially when they're comparing it with other socialized medicine type of countries.
And I think people really don't understand that none of these countries is it totally free. Like when I moved to, actually live in Vienna, Austria. And when I moved there, in order to get my residence permit, I have global US out of pocket insurance, because if I go back to the US, you know, like you have to have this continuity. I then used that in the UK to cover what was private outside of emergency care. I had 2 of my kids had emergency surgery, and that was, you know, unbelievably free. But when I moved to Austria, they made me get an Austrian policy. And when I went to the emergency room, because I hit my head on the door of my car, because I walked right into the door. I got the, you know, the Tesla and the wing, and it was brand new, and I was rushing around like trying to throw my 3 kids, and I walked right in. I had to go to the ER. Amazing experience, but I had to put down a €200 deposit, and then they refunded like 2/3 of that after I was seen in 20 minutes. You know, like these things are not free just because you move to a new country, right? They are funded by the government for the citizens, and you have to have contributed to that society in order to reap the benefits of it. But I think when I was a doctor in the US, I really did not understand what that looked like outside the US. It just
Yeah.
seemed so foreign to me, and it seemed like, well, it's free. It must be, you know, buy
Mm-hmm.
cheap, buy twice. And that's not the way it is.
So I wanted to go to you, Rui, and ask you a question about trust. So one of the challenges, of course, of what we all are facing as clinicians dealing with patients, is there's trust is being corrupted a bit, a lot of it from misinformation, disinformation, bad experiences with the healthcare system, stories that are true and accurate about misdiagnoses, etc. How do you work with the patient population that you work with? And from our conversations before, they're from different demographic groups, different languages, different backgrounds. How do you build that trust to improve their health in the long term so that they aren't thinking, well, I'm getting a lower cost service and therefore I'm getting short shrift, or I'm getting a cheap type of healthcare versus one that's really meant
That's a
for
great
me?
question, Adam. I think we have to understand trust and in terms of health education and what we hear. It's different in urban settings, and I think it's even more exacerbated in community and rural settings, right? Because how do you get that information? You may be siloed in different ways. So for me, I would say what's very important, as you probably know, in Piedmont Health Services, our population, it's a lot of Spanish-speaking population. So we have to make sure that we are able to communicate our diabetes management in an appropriate way. So what does that mean? When we hire our providers, they have to be bilingual. Some of them have to be bilingual, right? In order to address those kinds of concerns. So that's how one way we can engage trust is the communication. We invest heavily in language interpretation services if you do not speak Spanish, to make sure that they fully understand that you need to come back in 3 months for your diabetes, or it will get uncontrolled, and these are the complications. So I would say in the community, in rural health settings, even more so, that point of trust needs to be hammered even more so, because already they have barriers to care getting into that appointment. It's a big effort to get them through the door. When we get them through the door, you should see like our no-show rates in our clinics. It's a big challenge. So once we kind of have a mini celebration when our patients come through the door. So once we're there, we need to provide that comprehensive care that we talked about earlier, from PHS to that patient, and understand there's dental, there's, if your PHQ-9 scores are high, we can immediately connect you with a behavioral health provider on site or remotely immediately. So there are different ways in which we can try to build trust. But it's key, right? With everything going on, what's really challenging is you read different things on the phones and social medias, and it's having that duty and responsibility as a primary care provider to share the updates, objectively, to our patients when they're through our doors. And I think that's been something we've been particularly proud of how we instill that trust. Yeah.
Amazing. Well, we've only got a couple of minutes. This has gone by so absolutely
This
fast.
has. I feel like we could keep going for hours.
I know. It's like so good. You talked about lifestyle medicine. I want to ask you, and preventive care, kind of one of the last two questions I have. One is around lifestyle medicine, and one will be wrapping things up. But I wanted to ask you about, you've done a lot of focused education, preventive care, and lifestyle medicine care. We are also hearing at the same time this conflation coming out of the federal government and the FDA, the CDC, and the current administration around healthy practices. How is that becoming a challenge for you as someone in the preventive and lifestyle medicine space, to ensure that there's not a conflation of some of the things that are coming out purported to be good, sound medicine out of the current Department of Health and Human Services, versus what we know from an evidence-based perspective?
I think the key with this, and this point about lifestyle medicine is, in its core, it's about the 3 tiers of prevention, right? Primary, secondary, and tertiary prevention. So, for instance, I think the way the healthcare system is built right now, when we go to medical school, we pick a specialty, right? Pediatrics, emergency, gastroenterology. In its essence, you're in the world of secondary and tertiary prevention, right? So for a cardiologist, you need to kind of have angina, some ischemic heart disease, for you to be the cardiologist, right? And that's a whole different kettle of fish, where the whole system is sort of designed for you to be, quote unquote, sick in the sick care system in order for physicians to reimburse for their services. Lifestyle medicine, on the other hand, and it's great that you and I both are boarded in this and very interested to see where this goes, is you're really focusing more on that primary prevention side, right? So before that patient becomes symptomatic or sick, or before that LDL is raised, what can we do to increase the longevity of that patient? So you probably know this more than anybody, the 6 pillars, stress, sleep, nutrition, um, uh, exercise, social connection, and avoiding risky substances, those pillars really focus on that primary prevention. And that's the upstream effect. So I think we spend, $5.1 trillion in healthcare in the US, and they say 90% of that is chronic diseases. And of that, it's preventable lifestyle measures, right? That sort of trickle down into our care. So to your point, I always go with the evidence base, right? That's the only thing that we as physicians, we should be telling our patients. And I think that's how we try to instill that. And I think as we go ahead, there'll be more, opportunities for lifestyle medicine, primary prevention, interventions to be embedded into clinics, outpatient or inpatient, in order to get those services. But it's still early days. But yeah, it's very exciting to see what the future will hold.
Lara,
I was really hoping Swedish Fish was going to be on that list.
I know, or Colin the Caterpillar. Colin the Caterpillar, like gummies from M&S.
No, or salted licorice. Like, I really have a thing for salted licorice, and I think that that's like a double whammy because just the licorice root and the salt are not good for my blood pressure.
No, Laura, those are gross. Well, listen, we only have a minute.
It's so good.
Rui, last question we ask all of our guests on this is like, is the healthcare system in the United States hopelessly broken and unstable to the point it's unfixable? And if it's not, what do you think we need to do about it?
Wow, what a great way to send me off, huh? Let's see. Yes and no, right? So I think it's fragmented in certain aspects, but I truly, as someone that's a proponent of innovation and a proponent of someone that can, somebody that wants to improve health systems, I think there's space. And it does go back to, we need to focus on upstream. We do need to focus on right now, because when you're asymptomatic, it's not that glamorous medicine, but that maintenance when you are in your, say, 20s to 40s, those two crucial decades where you start to accumulate those risk factors that really start to then, sort of hockey stick up in your 50s and 60s. I'm a huge believer that if we can put systems in place where, and this is not just sort of like wellness, boutique kind of things, like real checkups, real annual wellness visits, real markers like apolipoprotein B, all these kinds of things. If we can start to mitigate that in your 20s and 30s and 40s and have a system where people get regularly checked out for those kinds of things, I think there's an opportunity to reduce that cost, that $5.1 trillion. So I'm hopeful that can happen, but it's just how we implement that and how we sort of integrate our services around that. Yeah.
This was a fascinating chat.
It was a really great chat. Rui Ariyapala, I just went with it that time, and I appreciate you being on. A doctor, a public health specialist, associate chief medical officer of a federally
Kiwi.
qualified. Yeah, well, I'm getting there.
With a posh public school accent.
Yeah, he does, right? So, but it's so great to have you on. Thank you for talking and educating us about how care is being delivered in North Carolina to an underserved population and how you're doing it well and how you're creating some of those connections and also some thoughts for the future about preventative care. And so thanks so much. We really appreciate it.
I mean, I wasn't sweating too much, so I thought you could have had more trickier questions, but I enjoyed that.
Good. Well, any guy from Harvard can handle it. So, So,
you can just use your ego as like a shield, like a deflector.
We're just. What is it? I said the other day we're taking a piss, and they're like, no, Adam, it's called
taking the piss.
The piss. So I'm learning. I'm trying to learn. So anyway, have a wonderful day. Thank you so much, and keep listening. And make sure you like and follow us at Unstable Vitals.
Thank you for having me.
Thanks so much.
Thanks for tuning into Unstable Vitals. If you enjoyed this episode, make sure to follow us for more unfiltered conversations on the pulse of healthcare. Connect with us on LinkedIn or visit us on unstablevitals.com to stay in the loop.